as the number of people who are using pentacam is increasing and the number of ways we are using the pentacam is also increasing. So meetings like this are really very relevant. In the vast spectrum of, why am I not able to advance my slides also? Can you help me?
Ma'am, just move your mouse, ma'am, and press it in the center of the screen. It should move. Move your mouse and press it in the center.
Yeah. Okay. Yeah. So in the spectrum of corneal thinning diseases, keratoconus, keratoglobus, and pellucid marginal degeneration are distinct entities which come under the umbrella of corneal ectasias. Now, although each of them have distinct clinical and topographic characteristics, sometimes they coexist. And they may coexist in the same patient or they may coexist in the same eye. And that makes diagnosis more difficult and the management less straightforward. So what I would like to do is to take you through a few cases where we have found these diagnostic complexities and how we used, exploited different features of the pentacam to try and unravel them. I realize that all of us are seasoned, have been using the pentacam, so this slide is really redundant for most of you. But I would just like to emphasize the importance of making these measurements before the ocular surface is disturbed by either any drops or any other procedure. Like any diagnostic tool, the reliability of the measurements depends on the attention we pay to these little details. So here is the first patient, an 18-year-old young lad who came with a cornea that looks obviously steep. Now with the Placido-based system, we have a bunch of indices which are displayed, and these don't seem to make up their mind about what cornea is about. And even though some of the indices are obviously abnormal, they don't fit into the criteria for a keratoconus screening device, screening software that is the most popular in these devices. Now, capturing the same surface with a Scheinpflug-based instrument gives us a host of new information. It tells us, for instance, although the SIMK values are more or less the same, it tells us how much and where the steepest part of the cornea is and how far removed it is from the thinnest part. And if you look at the box on the lower right corner, you will find that it displays this disparity between the location of the pupil center, the thinnest point, and the K-max. And when you see such a disparity, you know that such a cornea requires greater scrutiny. Now, you would expect a cornea with such a high K-max to be a highly prolate cornea. But in fact, this isn't. And if you look into this box, you will find that a predominant part of the cornea is actually oblate. Now, when you look, although going back for a minute, now when you look at this cornea, it seems to look sort of featureless. And that is because of the color coding and the scale that we use. Now, if we want to look at further details, we need to first change the scale and use the tangential curvature map to be able to pick up subtle changes. And now we're beginning to see that there is an annular mid-peripheral steepening in the mid-periphery, which corresponds with the area of a mid-peripheral posterior elevation. But if you look at the thickness maps, you will now find several areas of peripheral thinning. The important thing is that these parts of peripheral thinning lie beyond the area of steepening. This is a feature that is typical of PMD. You will also notice that the thinnest point is far removed from the steep area of the anterior surface. Not only this, you will look, when you look at the corneal thickness map, you will notice that the cornea is globally separated. Now, the elevation, again, was not significantly high. And that is the reason why the enhanced ectasia display does not pick up a keratoconus. Remember, the previous speakers were talking about how this is formed, and this is based on elevation, not on curvature. And therefore, even though the cornea has got a steep curvature, the elevation was not too high. And that is why it is negative for keratoconus. And if you look at the corneal thickness spatial profile, you'll find that the profile is more or less flat, again, suggestive of a PMD. When you look at the Scheimpflug profile, the most obvious feature is the keratoglobus, but in the periphery, you also see a PMD. A second case, where the cornea looks somewhat similar to what we saw the first time, with almost a similar Kmax, but here the corneal thickness pattern is different. You find that the highest elevation more or less corresponds to the area of thinning, which is very typical of a keratoconus. So there is no doubt that this patient does have a keratoconus, but again, the Kmax is far removed from the area of thinning, and this cornea is not as prolate as you would expect it to be. Now, when you go back to these 6 maps, you'll find that there are areas of paracentral steepening, which correspond to areas of corneal thinning, and that the keratoconus is undisputed in this case. But in addition to this, you see these areas of peripheral thinning, again, which lie beyond the area of mid-peripheral steepening, suggestive of a PMD. So this eye seems to have a combination of a PMD and a keratoconus. And when you look at the enhanced ectasia, the posterior cornea still it picks up the keratoconus. The corneal thickness spatial profile is flat, but has a somewhat downward trend. And the Scheimpflug contour has both the elements of keratoconus and the PMD. Now, in these cases, in this particular case, the aberrations that the pentacam offers is also very useful in these cases. Notice that the cornea, if you recall, was an oblate cornea, and an oblate cornea typically is associated with a positive spherical aberration. The negative vertical coma is a characteristic of keratoconus. So even from the aberration profile, you see a combination of PMD and keratoconus. A third patient with an obvious superior steepening, this looks like a superior horseshoe, but the thickness pattern is very different. The corneal thinning seems to be occurring not in the steeper part where you would expect, but in the flatter part. The reason for this, for me to show this patient, is to show the importance of coverage, as Kitansha pointed out some time ago. By default, the pentacam gives us an 8 millimeter coverage. But when we are looking for peripheral pathology, it is important to expand this coverage. And now when you expand it, you see that the little area of thinning that was lying obscured by the 8 millimeter coverage now starts to show up. So this explains why the thinning is more on the inferior side, although the steepness of the cornea is more superior. And when you look at the Scheimpflug contour, you will then see elements of both the superior keratoconus and an inferior PMD. Again, a very unusual combination. And finally, this patient who has a steep cornea where the corneal thinning and the posterior elevation all seem to coincide. The patient has got a high negative prolate, a hyperprolate cornea, which all seems to fit in. So it has keratoconus written all over it. But if you look at the anterior chamber depth, it is unusually high. Now we go back to these 6 maps, and while the keratoconus is quite obvious, notice also that there is an element of PMD where the thinning that occurs in the periphery beyond the area of the steepening, but also notice that this cornea has a global thinning. So this is a very unusual situation where we find elements of all 3 ectasias in the same eye. The ectasia enhanced ectasia display picks up the keratoconus. The corneal thickness spatial profiles picks up the combination of keratoconus and PMD, where it is flat with a slightly downward trend. And if you see the thickness map, you see that the thickness extends almost limbus to limbus. Now, again, the aberration display is very useful. We can make out that when 3 ectasias are together, obviously this cornea is highly aberrated. And if you notice that there are aberrations, higher order aberrations, even up to the 6th level, are unusually high. But what is interesting in this combination is what it does to the spherical aberrations. The keratoconus tends to create a negative spherical aberration. The PMD tends to create a positive spherical aberration, and they to some extent compensate for each other. Just to put it in perspective, this is how a normal cornea would look with a very low spherical aberration. This is how pure keratoconic cornea with about the same refractive error in all 3 patients. But here the spherical aberration is very high value. So the combination of keratoconus and PMD seems to bring the spherical aberration down, but of course the other higher order aberrations are extremely high when there are multiple ectasias. So the Scheimpflug image confirming that there is an element of keratoglobus with a normally high anterior chamber, a globally thin cornea, a keratoconus in the center, and a PMD. And just to take you back to where we began, if we were to go back in time, and if we had just stuck to the placebo-based system, we would have remained clueless in this situation. Thank you very much. Now, just to summarize these what I learned in these looking at these maps is that these ectasias sometimes do coexist, and we need to exploit different features of the pentacam to be able to put these jigsaw pieces together. And when we do that, we're able to disassemble the complex nature of these corneas. But of course, what the question that remains unanswered is whether all 3 are really part of the same broad spectrum of ectasia, or are they different, phenotypically different diseases or variations of the same? Thank you so much.
I think excellent presentation, ma'am. Excellent presentation. And your such fantastic cases have confused the pentacam also.
Thank you, Namrata.
Excellent presentation. I mean, this is these are such rare cases, and to have all indices of those.
Thank you so much. Thank you.